Okay, so good morning everybody. My name's Jude Cottrell and I'm a midwifery educator at Auckland District Health Board, and I'm here to talk with Helen today. So Helen, could you introduce yourself please?
Well, I'm Helen Evans and I'm a paediatric hepatologist and I work at Starship Hospital, and a hepatologist means a liver specialist.
Right. So we're going to be talking about jaundice today, but before we start, can you tell us, Helen, why we need the Beware Yellow campaign in New Zealand?
Well, we introduced the Beware Yellow campaign about 2 years ago to coincide with World Rare Diseases Day, because the patients that we look after with liver disease, the diseases themselves are very rare, but together they form an important group of diseases in newborn babies. And what we recognised from our own experiences at Starship is that the babies tend to come to us later than they do in other countries. And early treatment is very important, particularly for one of the liver diseases called biliary atresia. And the reason early treatment is important is because there's an operation that can be done called the Kasai. And we know from experience everywhere in the world that the Kasai is the most successful if it is done early.
How early do you mean?
Before the age of 6 weeks is ideal, 8 weeks at a push, but beyond 8 weeks the chances of the operation being successful greatly diminish.
So when we've got babies coming to you later than other countries, is that because we're missing them?
Well, I think there's a number of reasons for it. We do, of course, have a different ethnic group here in New Zealand, and we know that some of the liver diseases are more common in Maori and Pacific Island children, and particularly biliary atresia is more common in them. And we really don't understand the reasons behind that and are currently investigating whether there is perhaps a genetic component. But jaundice is more difficult to recognise in infants that have a darker colour skin. There is no doubt about that. And also breastfeeding rates here are relatively higher than in some other countries. So breast milk jaundice is quite common. And of course, for a midwife and a GP and a community health professional, recognising the infant with liver disease in amongst the vast number of children with breast milk or physiological jaundice is really very challenging indeed. So essentially, Beware Yellow is about trying to raise awareness of early investigation of jaundice in babies, not just amongst health professionals, but also amongst parents.
Right. So Helen, why should midwives be worried about a baby that looks otherwise well? And I'm interested in the physiology here.
Well, that is a very important question, because at first newborn babies with liver disease do look well and they feed well, they grow well in the initial few weeks also, but as time goes on they will become malnourished and they will stop gaining weight. And often the subtle signs at the beginning are poor weight gain and jaundice. But to all other degrees, the babies behave normally. They smile at the right time, they interact normally with their families, and it's only as they get to be weeks of age that we start to see these signs of liver disease setting in. So important features, particularly for the biliary atresia babies, are that their stools are pale, or their poo or their faeces or whatever you want to call it, and their urine is dark. And I think what we don't appreciate as adults is that babies can't concentrate their urine. So they can never make a dark urine just because they're dehydrated, for example. So if their urine is dark, that's because there's pigment in it, and that pigment is bilirubin, or jaundice essentially, coming from the liver.
Which should have gone through the bowel.
Exactly.
So before we go on, just explain a little bit about actually what's happening with the biliary atresia.
Well, with biliary atresia, there are no bile ducts, and bile ducts are the little tubes that bring bile, which is the waste product of the liver, from the liver into the intestine. And if you don't have those tubes, then the bile builds up in the liver and it damages the liver. And that can happen, it's progressive, so it happens initially relatively slowly, but then it becomes quite progressive. And these children, if we didn't do anything to them, would die within the first year of life of severe liver disease.
Right. And if a baby doesn't get diagnosed early, why is that dangerous for the baby?
Well, it's dangerous because they miss out on the opportunity to have the early operation, the Kasai, which we can never replace the bile ducts, but we can use a piece of bowel to divert the bile from the liver into the rest of the bowel.
Right.
And so if that doesn't happen early enough, then the baby develops end-stage liver disease, what is known as cirrhosis, like an alcoholic adult would have. And they can die of that liver disease or cirrhosis very early, within the first year usually.
Right. So how successful is the Kasai procedure on most babies?
Well, overall, we currently here in New Zealand, we achieve what we call biliary drainage in about 60%, and that means that we start to see the baby losing their yellow colour and we start to see bile coming through in the stools again. But if in other countries overseas, they report slightly higher rates, 70 or 80% of early biliary drainage. But even if you achieve biliary drainage, some of those children will still go on to have liver disease and need a transplant. So overall, probably about 80% of our babies will get a transplant at some point in childhood, whereas in countries overseas, that is more like 40 or 50%.
And we don't know why our stats are worse.
Well, we believe they're worse because the patients come to us later and they're having their operation performed later. So the liver has already sustained quite a lot of damage before they have their operation.
And how many babies in New Zealand a year would we have that actually need a Kasai, or children that end up having liver transplant for this reason?
Well, this is very important because there's only about 7 children a year who have biliary atresia, born with biliary atresia. And so recognising those 7 in amongst all of the other babies with jaundice is very challenging indeed. But if we look at children who have liver transplants, then the biliary atresia patients account for the majority of them. And the issue with that is livers don't grow on trees. We have to get them from somewhere. They either come from a live donor, which puts that donor at risk, or they come from deceased donors, and we don't have an endless supply of deceased donors. And in fact, here in New Zealand, we have one of the lowest organ donation rates of the whole world. We don't really understand that either, but it's quite clear that we have not been able to improve that rate in recent years terribly much. And so basically, if you end up needing a liver transplant, you have about 10 to 15% chance of dying before you get your transplant. So any child that we can save from not needing a transplant is very important, because then that releases the livers for those patients who really, really do need them. And there are some liver diseases which we don't have much ability to intervene. But in biliary atresia, we do, of course, have the option of the early operation. And if we could do that as early as possible and make it as successful as possible, then we would save children from needing transplants further down the line. And that benefits everybody. It benefits all of the children on the waiting list, and it benefits the biliary atresia patients themselves, because living with a transplant is not straightforward either.
No. So just to finish up for midwives, the diagnosis of this is, give us some really clear bullet points so that they can make a differential diagnosis from just normal common breastfeeding jaundice.
Yes. Well, a baby with biliary atresia will be jaundiced, and in the first few days and weeks that may be subtle, and they will have pale stools, not necessarily white, but pale, and they will have dark urine. Now, of course, if you have a pale stool sat on top of dark urine in a nappy, you may miss the fact that the stool is quite as pale as it is. But those are useful pointers as to babies who deserve to have a blood test to see do they have jaundice that we're worried about. So anybody who has pale stools or dark urine or is jaundiced beyond 2 weeks, we believe should have a blood test called a split bilirubin. Now, a split bilirubin looks at the total amount of bilirubin in the blood, but it's a bit more sophisticated than that, and it breaks it down into unconjugated bilirubin, which is the type you see with breast milk jaundice, and conjugated bilirubin, which is the type you see in liver disease. So you then have a really great way of knowing, is this a baby that I need to worry about? Because if it's all unconjugated, they probably have breast milk jaundice, and you can wait a bit longer before doing any other tests. Whereas if it's all conjugated, the baby needs to be seen by a paediatrician.
And just tell us what conjugated bilirubin is.
Bilirubin is made from broken down hemoglobin or red blood cells. And initially it's what you call unconjugated. It comes to the liver and the liver conjugates it, or it just undergoes a biochemical reaction. And once it's conjugated, it is then excreted into the bile and from there into the bowel. So the conjugated bilirubin is the sign that there is a problem with the liver, whereas unconjugated bilirubin is generally just a sign that it is physiological or breast milk, because this just hasn't yet been conjugated by the liver. And the reason that happens is the liver is immature at that stage, and that enzyme is just not working as effectively as it will do.
So on our lab test forms, what do we tick to get that?
We should tick bilirubin and then physically write split bilirubin. Now in Auckland we've been very fortunate because we've made a relationship with Lab Tests Auckland, and in any infant below the age of 6 months, if we were to only tick bilirubin on the blood form, they would do a split for us.
Right, so they don't need to, in Auckland they don't need to write that, but in other parts of the country
They do,
you tick
yes.
bilirubin
And then write split bilirubin. And we're trying to work with the other labs around around the country to ensure that they all take on this new process of automatically doing the splitting.
Marvellous. Okay. Where does the role of family history come into this? Is that a significant thing for midwives to know about, if there's a history of this?
I think it is. Biliary atresia isn't known to be genetic, but what we do know in New Zealand is that we have clusters within some whānau, or extended whānau. So for a Maori patient with a newborn Maori baby with jaundice, we would worry that that was biliary atresia. And actually, because the disease is commoner in them, we would certainly want to know about a Maori infant with jaundice very early. But there are other genetic liver diseases as well. So there's a syndromic disease called Alagille syndrome. There are all sorts of inherited forms of jaundice. Alpha-1 antitrypsin deficiency is the name of one of them. And so even if it isn't biliary atresia, it may very well be something else that needs us to see them. So family history is important because there may have been other children in the family with liver disease.
Well, that's good, Helen. That's really interesting. And other resources that you've produced that midwives could access?
Well, we've produced a series of posters about Beware Yellow, and some of these are for families, others are for healthcare professionals, and we've had them translated into different languages to appeal to the families in particular.
So what languages have you got?
We have Maori, Samoan, Tongan, English and Mandarin.
Fantastic. And can midwives get those little
Yes,
pamphlets?
midwives can have these. So some of them are written for families and some of them are written for health professionals. So the health professionals ones tell you what blood tests to do, whereas the family ones are more targeted at focusing on whether the stools are pale and whether the baby is jaundiced. We've also produced some pens which we're rolling out for midwives, which inside them have a very handy stool colour chart which shows which colour stools we should be worried about. So it shows these normal colour stools at the top and the pale stools at the bottom.
Marvellous.
And other resources
How can we get one of those pens?
Well, we plan to send one to each of the midwives in the country.
Oh, nice. And some of these resources?
And the resources as well.
Good. And if they want to look online for further information, is there somewhere they can go?
Well, we are working with the Paediatric Gastroclinical Network in New Zealand to publish our algorithm of investigation of babies with jaundice to try and simplify it so it makes it less confusing than it was perhaps in the past, and that will clearly say which babies need to be referred to a paediatrician versus those which need to be seen by a GP. So that will be one important resource that we will be putting on the Starship Hospital website and the Paediatric Society Clinical Network's website. Other resources, there are apps which are very useful, one from the Children's Liver Disease Foundation in the UK which has the stool chart on a smartphone application, and there are similar ones in the States.
So you would get that how?
You go to the App Store on your smartphone and they are actually free to download.
Wonderful. Anything else you think midwives in New Zealand would like to know about your lovely project, Beware Yellow?
Well, I think one of the things I'd really like to say is that there's perhaps been a perception that midwives are missing babies with jaundice, and I really don't see it like that. I think that baby jaundice is a problem for all of us, actually. It's not a midwifery problem. It's a problem for GPs, paediatricians, specialists as well, and sometimes these diagnoses aren't easy. So I think this Beware Yellow is about working together to do what's best for the babies and to improve long-term outcomes. It's not about saying that one group of healthcare professionals is missing these early diagnoses. And of course, a lot of the referrals will come from midwives, because midwives are the professional group that see these babies at that time of the life when we first pick up the disease. So by definition, it's always going to be midwives seeing the children. But of course, we all play a role in this pathway. And I think, again, I just reiterate, it's about working together.
Lovely. Well, Helen, thank you very much, and I hope the midwifery profession can really play their part in that, because it's a rare thing, seven babies a year, isn't it, in the whole of the country?
It is.
But really, really significant that we don't miss those.
Absolutely.
Thank you very much.
Thank you, Jude.